Hello and welcome to another episode of Dr. Sill's Intern Diaries, where I talk about my experience as a junior doctor in Sydney, Australia. In this episode, I'm going to talk about my time in the aged care team, so all things geriatrics, and also I'll talk a little bit about the general realizations that I've had as an intern during this time. Talk a little bit about money and a bit about working hard versus working smart. All right, let's get into it. I want to start by just acknowledging how lucky I've been this year. I feel like my year has progressively gotten harder and harder as my skills have gotten, better and better. So I started the year with mental health rehab, which was basically where I had a group of patients that were medically stable and I just had to deal with all the medical issues that came up. So it was pretty low intensity, no emergency kind of stuff, and just had to kind of do the diabetic screenings and deal with headaches and sore tummies and sore calves or whatever. And it was pretty well supported during that term. And then it kind of got up a level in difficulty where I joined the trauma surgery team. I was, in a pretty big team. There was like 3 registrars, me, and then there was always a consultant in the hospital. And so although that was harder in terms of the complexity of the medicine and the surgical requirements of patients and that kind of stuff, and the stability of patients, it was easier because there was always a registrar around that I could ask questions from. So I was always well supported. And when people were really unstable, they would just go to the ICU very easily, which meant that they were the responsibility of the ICU team rather than our team. So we would just be the kind of consulting service. So if someone had a code blue, it was the ICU team that would go and manage the code blue, not like me and my team. So trauma surgery was just a little bit harder than the mental health rehab term. And then now I've just finished my aged care term. And that has been just a little bit harder than trauma surgery. It hasn't necessarily been hard in terms of complexity of the medicine, the kind of clinical side of things. It's been more difficult just because it's a smaller team. So it's just me and a registrar, and we work together to take care of, on average, 18 to 20 patients. And that's quite a lot of patients for 2 people to take care of. It's okay if they're mostly stable, but a lot of them were sick a lot of the time. So it was pretty long days trying to stabilize people and get them to rehab or get them back to a nursing home or get them back to home. So the workload was larger and the responsibilities were higher as well, because I couldn't always just ask my registrar for advice if they were busy in clinical, for example. As a bit of a summary of what it's like to be an aged care intern in Australia, the day kind of starts at 8, but I would get there pretty early, maybe 7:30, sometimes even 7, depending on the day, and kind of pre-round, so go through, do an electronic file review of all my patients to see all the issues that came up overnight. And I would get all that kind of dot pointed before even seeing the patients physically, so that I would know the things to focus on with the registrar. Registrar would do that as well, and then we would meet together and start to round. Now, depending on where you are in the hospital, you have a MDT, so a multidisciplinary team meeting, where you meet with all the allied health staff. So that's people like occupational therapists, physiotherapists, and social workers. And you basically go through all of your patients and all of their allied health needs so that you can get them discharged home without issues. It's probably a good time right now to talk about allied health because it's an important thing to know about. So from an intern's point of view, you want to get people discharged when they're medically stable. Then the goal is to get them home as soon as possible, because being in hospital is not risk-free. You can get clots and infections, and if someone's medically stable to go home, they should go home. They shouldn't stay in hospital unnecessarily. And the allied health people are essentially the key factors in getting aged care patients home. There's 4 main allied health professionals you work with, maybe 5: speech path dietitians, social worker, occupational therapy, and physiotherapy. But in the meetings, it's really the 3, social worker, physiotherapy, and occupational therapy that get people home. Occupational therapists are really about functional assessments, so getting people to do the things that they would normally do in their life. Go to the toilet, cooking a meal, making a cup of tea. These things are pretty important if you're going to go back home. Physiotherapy is all about getting the strength back. So if an 85-year-old gets pneumonia, their legs weaken because they're in hospital for so long and they decondition. So physiotherapists are involved from day 1 to get them stronger so that they can go home. And sometimes you need to not take them home, but take them to rehab. And then there are social workers. And social workers essentially do all the things that doctors don't want to do. They sort out home services. They give psychological counseling. They are bereavement professionals, so they help if there's been big changes. They update the families. They do a lot of family meetings, all these kind of things that the registrars and the consultants don't have time to do. And as an intern, sometimes you get to do. These three kind of professionals, the allied health group, you have to know a lot about them as an aged care intern, and you need to know the people. It's really important that you know them by name, that you can call them anytime, bring up issues whenever an issue comes up. If you can't, it slows down people going home. So back to the kind of day, normally you do that file review first thing in the morning, and then I would have the MDT at around 8:30 a.m. where I'd meet with all the different allied health professionals. That's kind of the first time as an intern I was giving presentations, because it's a bit weird, but as the intern, you're actually running the meeting. You're kind of like chairing it. So you go through your patient list. You go through the patient, you say their name, you say what their medical status is and where they're up to with their medical treatment. So I might say, this is a guy from home with a pneumonia. He's on day 5 of antibiotics. His inflammatory markers have now stabilized. He's ready for going home. Social work, where are we up to with services at home? Occupational therapy, how is he with function? And physiotherapy, is he deconditioned or can he be independent with mobility? And then they would all give their updates to me, and then I'd have to report back to the team. And when you have 20 patients and they each have different issues with the different allied health professionals, it can get a bit cognitively overwhelming, and I totally forgot things from time to time, which I don't think caused too many problems in terms of discharge planning, but maybe anyway, it's hard to remember everything. So you're writing down frantically during these meetings. It's also good presentation practice as well, though. If you need something for your CV, you can always say that you ran the MDTs. It's not a bad idea, actually. Maybe I'll add that to my CV one day. When the MDT is over, you can then start with your rounds. And so that's when you go with your registrar or your registrar and your boss, and you go and you see all the patients and you talk to all the patients and you get a list of all their issues. And then, one patient might have rheumatoid arthritis and a sore joint, and so you need to then get your list of jobs, which might involve calling the rheumatologist and finding out what medicine this patient normally takes for a flare, and then you go and you add that to your jobs list. And then the next patient had a fall overnight and hasn't had a CT brain, so you have to organize the CT brain. And the next patient, whatever, so you get your list of jobs to do for the day, you finish the round, and then you do your list of jobs, and that usually takes the whole day. And whilst you're going through your day doing all those jobs, organizing the imaging, the blood tests, the whatevers, you sometimes have to go to clinical reviews or rapid responses, and those are like little emergencies, sometimes big emergencies, where a patient is medically unstable. The other day there was a rapid response because a patient went from a breathing rate of 16 or 18 per minute, which is pretty normal. Above 10, above 12, less than 20, that's normal range. But they would then started to breathe at 35 breaths per minute, and they were desaturating. And so it was whoa, you don't want to undervalue the importance of a change in breath rate. Yes, sometimes it's anxiety, but that's a diagnosis of exclusion. You need to find out what's causing an increased breath rate, because it can be really, really serious. People can, a lot of things that can kill you start by increasing your breath rate. I hope you're not watching this getting anxious and increasing your breath rate, by the way. So that patient, I think, ended up it was actually just a pneumonia that was getting worse, but could have been having a massive PE, a pulmonary embolus, which would have been an emergency. And so that's an example of some of the things you might do throughout your day. It was actually good to do aged care and trauma surgery, because trauma surgery, which is the term I did before, was a term that required you to interact with all the different surgical specialties. So if someone was in a car crash, I would be talking to neurosurgery and orthopedics if there was broken bones, and sometimes I would talk to gastroenterology if there was a bleed, or interventional radiology if I needed some procedures done. So I would be working with a lot of different specialties, which is really good because you kind of understand the things that each one looks for, so it gives you that broad sense of knowledge. It's very similar in aged care. So in aged care, your patient group isn't just a group of people that have kidney problems, right? You're not in nephrology. You're dealing with just people in an age group which have problems in a wide variety of different systems. So I'd be calling hematology, nephrology, urology, orthopedics sometimes, a lot of different specialties. So I would have to learn a little bit about all the different teams medically, which is great as well because it gives you that wide base, which is kind of what I was after. So now I've talked a little bit about what it was like working as an intern in aged care. I want to now talk just a little about some of the interesting realizations that I might have had during the term. I think the first one I want to talk about is working part-time. I can definitely see myself one day working part-time. I think when you're a junior doctor, or especially when you're in your training program, it's a bit harder. People do it and it can be done. But as an intern, it's hard. As a resident, it's possible. But as a registrar, it's also a challenge. That being said, when you look at what registrars have to do, which is essentially work more than full-time hours and study for impossible exams, it's so unreasonable to work full-time and study for the exams. Some of them have kids, so that's 3 things which are like more than full-time workload each. I'm like 90% sure that I would work full-time if I have kind of training exams coming up, like registrar level exams coming up. And I think I just want to promote that idea, because a lot of them, you know, they're destroying themselves mental health wise. They finish work at 5-6 p.m. and then they're studying till 10 p.m. Then they sleep averagely and then they come back to work, and there's no balance in their life. As a registrar, you're earning between like 90 to 100k a year, which means if you go part-time, half-time, it's 50k a year roughly. That's enough to live on for 1 year, and you only have to do it for 1 year, because that you just have to do it till you pass the exam. So if you have more time to study, then you increase your chance at passing the exam, then you can go full-time again. And if you think about it, it actually saves you, it actually makes you a lot of money, because if you were going to fail the exam, then you have to do an extra year of training, which means you're a consultant 1 year later. But if you do go part-time 1 year and then you can become a consultant 1 year earlier, then you make $300,000 a year, or whatever you make as a consultant, 1 year earlier, because you didn't fail the exam, because you took time off to study for it properly. I don't know, that's just what I think. I think taking some time off is a good idea. I think we're all, if you're in my age group, like in your 20s and doing medicine, I reckon we're probably going to be living to around 100 years old and easily working like till we're 80, because with the advancement in technology and health, the health span of people, especially in our age group, is going to be much longer. So like, we're doing exercise every day, we're eating well from a young age. That means our longevity is going to be significant. We're going to be working till older. So this is a marathon, people. Like, let's just chill out. Let's have a breather, enjoy a cup of tea, reflect. Don't work so hard. And the final thing I wanted to talk about was kind of how in the last couple of weeks, I'm not sure when you're watching this, in Sydney, Australia, we've just seen a kind of big rise in cases of COVID. In the last month is really when COVID went from being a news article to being a reality for me. Because obviously in the hospitals we hear about it, we've been planning for it, we've been mixing up the wards and splitting the teams such that we can be prepared for it. But now it's here, now it's arrived, and that was just a kind of interesting experience as an intern to kind of see this thing that's been in the news for so long to kind of be right in front of you. And I'm working with COVID positive people now in full PPE, taking blood tests, taking histories, seeing them in clinical reviews and rapid responses and that kind of thing. And I will be talking a lot more about that when I do my Intern Diaries reflection for my relief term, which is what I'm doing right now because I just finished my aged care. So stay tuned for that. And finally, the last thing I wanted to talk about is the idea of saving for your death. Just a quick point to say that dying in a crappy nursing home is absolutely dreadful, and we all know that there are terrible nursing homes out there. They exist. You know, nursing homes, it's rough, right? Sometimes you have to put your parents in a nursing home, I get it. But if you just start saving at a younger age, a whole bunch of money so that you can afford 24/7 carers, then it's better than a nursing home. Like, dying at home is what most people want. This is an important fact. Most people want to die at home and most people die in hospital. So think about that and plan accordingly, because you're gonna die, and like, having a good death is a very important thing, and people often have terrible deaths because they don't want to think through their death or plan. So you need to think about it, and you need to start planning the services you're going to have, and palliative care. Get palliative care involved early, and get the community palliative care team will be really important if you want to die at home. All right, guys, I'm going to leave it there. I'm sorry we ended on a morbid topic, but you know, that's life. I wish you all an absolutely lovely day. Go give someone you love a big hug, and leave an emoji of an elephant down below if you've stayed till now. And I will see you all in the next video. All right, bye for now.